we're going to open the floor for questions. So we've got all our wonderful speakers here. Welcome, everyone. So our first question is for Alison. This question is the following. I am currently wearing CMG and have my target range set at 4.4 to 7.5. What is acceptable in terms of having blood glucose outside of this range while trying to conceive during pregnancy? I'm very focused on staying within this range, but my blood glucose still fluctuates daily. I use temp basal rates to prevent lows and correct highs. I eat low GI food and do general exercise each day. Any other tips on what I can do to regulate these fluctuations outside of the 4.4 to 7.5 range would be appreciated. Thank you.
Well, I'd have to say that with that range of glucose levels, you're doing exceptionally well, 4.4 to 7.5. What's acceptable during pregnancy is really quite an individual thing. Depends on where people are in general, starting off in their pregnancy. They can be starting with much higher fasting levels that we want to get down, but we have to bring it down, more slowly. Your temporary basal rates to prevent your lows and correcting your highs. Sounds like you have a good understanding of what you're doing there. You're doing some exercise. Sometimes sleep interruptions can affect your glucose levels and give more fluctuations with that. And also along with things like the time of day, the time of the month that it's at in preconception care. So your cycle can affect your fluctuations. But it really needs to be individualised. We do aim to have a fasting level. We'd like to get it down into the, fives. So for that, and then looking at pre and post meals, what your levels are like and adjusting insulin. As David mentioned in his presentation, rather than looking at specifically just HbA1cs or specific glucose levels, that amount of time that you're in range is really how we focus on things now. So I would say that looking at a 4.4 to a 7.5 range, you would be doing very well with that. But I would probably not have a lot to add to what you're already doing with your food choices being low GI, your exercise, and clearly keeping an eye on what your glucose levels are. Have you got anything, David, that you'd like to add to that?
Oh, no, I'd agree with all that. I think you just maybe have to be sure that your carbohydrate counting is as good as it possibly can be as well. I mean, it sounds like this particular person is very well, skilled in their diabetes management, but sometimes some foods people find harder than others to get an accurate fix on. So, if it's a fluctuation after meals, for instance, then seeking a bit of extra help from a dietitian may also be valuable then, and adjusting the mealtime ratios possibly so they're a bit different at breakfast, lunch and dinner if necessary.
Right. Thanks, guys. All right, the second question is for Professor McIntyre. So this one is, I have type 1 diabetes and have been on an insulin pump for 10 years. For the past 6 years, I have also been taking 1,000 milligrams of metformin/Divex tablets every morning. Is it safe to continue taking metformin whilst trying to conceive? Are there any side effects or potential issues that I should be concerned about?
Yeah, well, thanks for that. Well, so metformin, I guess we see much more commonly used in the type 2 situation. On average, I think the studies show that metformin doesn't really greatly improve HbA1c, for instance, anything beyond about 3 months in type 1. But for an individual person, it can be quite different, and some people notice benefit. The one thing that it does seem to do is slightly reduce the total amount of insulin you might need each day, or the total daily dose. So that can be a benefit for some. And if you have someone with type 1 diabetes who's also struggling a bit with being overweight, maybe you can have a little bit of help there. So they're the reasons you might use it. But if you go on the averages from the studies, there's probably not, in general, a huge benefit of metformin in type 1 as opposed to type 2. Now, we do consider it quite safe in the preconception time, and it's a bit different from country to country. But in Australia, I think a lot of people with type 2 women, for instance, would keep the metformin going once the pregnancy is diagnosed, but up the insulin and intensify the insulin treatment at that stage. So there would be no, if it was working for an individual person, then there's no reason to stop metformin as part of preparation for pregnancy. In terms of side effects, most people, if they're going to get the side effects, they're gastrointestinal, so nausea, vomiting and diarrhea. If someone's on it for a long time, we'd also be checking their vitamin B12 level, as that can be low on metformin treatment. But, so long as those general things are done, I think it's perfectly reasonable to continue metformin. But as I say, it's more type 2 than type 1.
Great. Thank you, David. The next question is for Ashleigh. What devices did you find beneficial in the lead up to your pregnancy planning?
So I had the CGM because we do have the pre-pregnancy subsidy now. So I used the CGM I used it for about 6 months beforehand, and the insulin pumps, I'm on the Medtronic 640G. So they were probably the most beneficial because I could track my blood glucose. I could send it to my diabetes educator every single week and just make even the tiniest of adjustments. Like, you may not think that they make a huge difference, but they really do. Like, even just changing 0.05 here or there can just like bring something from just above your control range down into your control range. So that was amazing, having the CGM for that. I also did a lot of finger pricking as well. Even though I did have the CGM, I'm probably one of those people who gets a little bit into management, and I just want to make sure that everything is actually what it says it is. But yeah, those are probably like the major 2 devices that I use.
Cool. Wonderful. Thank you. Our next question is for Alison. Is it true that that women with type 1 diabetes will be allowed to go to full term?
Well, that really depends on your individual, your pregnancy and how that's going along the way. Because with, did you say type 1 diabetes?
Yes.
Yeah. So type 1 diabetes, you're a little bit higher risk of some other pregnancy complications. So higher risk of developing preeclampsia, high blood pressure along the way and later in pregnancy. So you have to factor in those conditions as well. So something like that may not be your diabetes as such, but it could be higher blood pressure that might bring about the fact that you need to be induced or delivered earlier than your due date. So it's hard to make a blanket statement that you are allowed to go to full term. I think in general you'd find most healthcare teams do tend to like to deliver about 38, 39 weeks.
Cool. Thank you. We have one for Professor McIntyre. I have type 1 diabetes and have been taking Megafol 5 in preparation for pregnancy. Do you recommend any other supplements to take alongside this?
Well, I think the Megafol is a very good idea. As you probably know, that's about 10 times the dose that there is in the standard pregnancy multivitamin. But certainly in preparation for pregnancy, we also recommend a standard pregnancy multivitamin with some iodine as well in general. And you could take that alongside the higher dose folic acid as well. And that's just a general recommendation. The only exception to that would be the iodine side of it in women who had some sort of non-thyroid problem, but they'd need to discuss that individually with their caring doctor.
Great, thank you. The next one is for Ashleigh. Looking forward to listening to your podcast. Can you recommend any other resources or social support groups online or other things like this? Thanks.
So I don't know if the person who wrote in is type 1 or type 2. If you are type 1, I really suggest the type 1 diabetes bump baby and beyond Facebook group. So it is a closed Facebook group. They do have guidelines in their moderation, which means that, you're not going to get any really weird out there medical information. So we do kind of, the admins there do enforce that if you ask a medical question, everybody has to respond from their own personal experience. And then they always refer back to your medical practitioner. So I find that really helpful because I know that the information that I'm getting there is lived experience that may be relevant to me, but that they're not going to tell me anything crazy that could harm me or my baby. I also found listening to just I know that we do have diabetes, but general pregnancy podcasts and stuff like that really kind of helpful just to know what was happening on that side of things. And then I could kind of put 2 and 2 together for my diabetes. I touch in a lot with my healthcare professionals as well. I ask them some pretty weird questions. So would recommend if you've got a good relationship with your healthcare professionals that you can do that. There is also, I think, a few books and stuff out there. There was one, I think, by I can't say her name, Ginger Vera, that I was going to read and just never got around to it, but it's still on my list. So yeah, Facebook, face-to-face groups as well. So I find it really helpful. I have a diabestie and she had her babies before I did, and I touch base with her probably every week or so to ask whatever weird question I have. So if you can find other women, do that.
Wonderful, thank you. The next one is for Alison. Hi, Alison. With the new Dexcom G6, if I already wear the Dexcom G5, can I also apply to get the G6 as a replacement?
Yes, you will be able to apply for that. It'll just be a matter of some more paperwork being done. And it's not available just yet because I was actually updating someone's paperwork today and printed off an NDSS form, and the G6 hasn't appeared on the paperwork yet, so it's not available. They're usually very quick as soon as something's available to redo the NDSS form, but it will just be a matter of getting another piece of paperwork done on your for access. Your healthcare professional just ticking that you want the G6, and then your access will be updated for that, and you'll be able to get because it's quite a new little kit. The application for putting applicator is a little bit different. It's more of a dome shape. It's much easier than the current one. Sits a little bit flatter, so I think it will appeal to people a lot more. And they are saying that you won't need to do the calibration, the 2 finger stick tests in once you've applied it, and you won't need to do any calibration. So probably might need a quick little bit of education as soon as you do change over, but it will just be a matter of paperwork. The paperwork's easy to be done now because at the moment, due to COVID, we're not needing to get anyone to sign their paperwork. So I'd recommend as soon as you hear that it's out there, just maybe contact your healthcare team, get them to submit the paperwork through NDSS because they do have to sign off on it, and that should initiate it all fairly quickly, although there might be a rush on it, which can sometimes delay applications being processed. It's just that chain of paperwork needing to be done. They said June, so it shouldn't be too far away.
No, hopefully not. Great. David, what are the real risks to pregnancy of low blood sugars early in the pregnancy, and likewise the risk of high blood sugars during early pregnancy?
Okay, well, the risks of low blood sugar, people often worry about this from the baby's point of view, but actually the baby is quite well protected from hypoglycemia. There's a number of mechanisms that ensure that even if the mother's blood sugars go down, the baby will be protected. So the worry is more with the mother, and it's the same as having severe hypoglycemia at other times. But if you have a really bad hypo, you can end up having a traffic accident or being unconscious or even having a seizure or something like that. So it is something you need to do everything you can to avoid. And, some of the pump mechanisms and the monitors, the CGM, also often have suspend functions these days, which give you a degree of protection if you're on a pump. And that's often something we would consider if someone is on multiple daily injections but still having severe hypoglycemia, then we need to try and get rid of that to the maximum extent possible. And what happens sometimes is a woman is diagnosed with pregnancy and she suddenly gets unbelievably enthusiastic about dragging her blood sugars down as much as possible and sort of overdoes it a bit. So I think it's very important if you have been letting your diabetes drift a bit and not being too careful with it, and you find out that you're pregnant, to not suddenly do it all on your own and try and get everything sort of sorted out, to seek some attention, get some help. So you do get your blood sugars down, but you do it in a safe way, because it is really the hypoglycemia is a major thing we worry about in the early stages of pregnancy. And a lot of women have a decreased dose of insulin in the first trimester, the first 13 weeks of pregnancy. So that's important to anticipate that your insulin dose may actually drop before it goes up. Then about hyperglycemia, I guess that's mostly for the rest of pregnancy after the first trimester. And that's when the effects of excess is essentially too much sugar being transferred to the baby and all the risks of that, including excess growth, baby becoming more chubby in utero and being more difficult to actually deliver vaginally and that sort of stuff. So there's a lot of risk related to hyperglycemia, which tend to come in a little bit later in pregnancy. Later in pregnancy, it becomes much less common to have women with severe low blood sugars or hypoglycemia.
Great, thank you. The next question is for Ashleigh. Who was part of your support team and how did they assist you?
So I had quite a few people in my support team. So obviously my endocrinologist, who I touched base with every kind of 3 months or so, to just kind of, she kind of took the high level care, so made sure that everything was underway that should be underway, that I'd been doing all my foot checks and my eye checks and everything to make sure that I was actually in peak health, things and doing things like kidney function checks and stuff like that. So she kind of took that high level view, and then my diabetes educator worked with me really closely on getting my pump settings quite right. Which was super helpful, and she's just super lovely and easy to approach. So whenever I had some issues with blood sugar levels, she just worked with me and she was happy to test different things with me to try and get me to where I needed to be. I found that my GP was also really a good part of the team, because whenever I needed referrals somewhere or suggestions on people to go and see, or even help getting into clinics, he was really helpful with that. So when I was first pregnant, he basically hounded the hospital to get me in like instantly, which was awesome. I also did have a lot of contact with psychologist support beforehand as well. So for just making sure that your mental health is okay, because pregnancy can kind of like put a strain on that. So I had quite a bit of support through that. And then obviously just all your normal checkpoints, like I've got a lovely optometrist, had been working with my podiatrist and stuff. So quite a few people, but I think it was all really worth it.
Excellent, thank you. Unfortunately, that's actually all we have time for this evening. We have run over a little bit. If you did miss out on getting your question answered, there will be another opportunity for this next week. Otherwise, please call the NDSS helpline on 1800 637 700 to talk to a health professional. They would be more than happy to help you.